Hello, and welcome to the webinar, Report Back from ASCO. What's the latest news in metastatic breast cancer? I'm Kate Vieira-Fitzer, the Metastatic Breast Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms. We believe no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. We have a few housekeeping reminders for you all. All participants will be muted during the presentation. Once the speakers finish presenting, we'll begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Shen is unable to give specific medical advice, so please keep your questions general in nature. We have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. The webinar is being recorded. We'll share the recording in a few weeks with all the registrants and will also be added to our website. Now I'd like to hand it over to today's speaker, Dr. Shen.
Great. Thank you, Kate. Hi, everyone. It's great to be here. Thank you so much, Kate. Thank you so much to Share Cancer Support for having me. I'm excited to share with you the latest updates in our field from our national ASCO meeting from this year. Before I do that, I just want to introduce myself. I'm Shen. I am a breast cancer medical oncologist at Memorial Sloan Kettering Cancer Center. I practice both in our Manhattan location as well as out in our regional network at our Basking Ridge, New Jersey location. My research interest is in targeting metabolic health for breast cancer patients. So that means optimizing blood glucose and diabetes, cholesterol levels, blood pressure, that sort of thing, both through lifestyle interventions and through medications to help get the best efficacy out of breast cancer-directed treatments, minimize toxicity, and improve heart health for our patients as well. And I'm also interested in developing new therapies for metastatic breast cancer and running clinical trials to test those therapies and bring them to our patients. So with that, I will go ahead and get started and share my screen. Great, so I hope this looks okay.
Looks good.
Okay, perfect. So like I was saying, I'm really excited to share the latest research from ASCO with you all, and we will be sure to leave plenty of time at the end for questions. I will say that overall, there's so much exciting new data coming every year, even throughout the year in our field. And as a result, the field of metastatic breast cancer really is becoming increasingly complicated as well. With all of our new data, we end up generating a lot more questions. So even with clinical trials that report new therapies that are really promising, we have a lot of questions that come out of that, like who's the right patient to treat with this kind of therapy? Is it better than the standard therapies that we already have? Is it more toxic? And what are those different toxicities that we should look out for? Does it work best in a certain patient population? And how can we tell that things are working? Are there response criteria that we can use particularly to that drug? So really we generate a lot of even more questions with every piece of research that comes out. So that'll be exciting to discuss. And I just want to say that, of course, this is not meant to be a guide to treatment necessarily. You know, for each individual patient, it really is a conversation between the patient and their oncologist about all the treatment options that are out there and the best particular treatment for that patient. And of course, shared decision making is so important and every patient is unique. So I'll go through all these data, but kind of at an individual patient level, it's still really important to talk to your oncologist about what the options are. So these are my disclosures. They're very few. This is the outline of things that I'll talk about today. So I want to start with hormone receptor positive, HER2 negative breast cancer. I'm going to talk about a study that came out that is going to help us rethink first-line CDK4/6 inhibitors in some patients, and are there patients in whom we can actually spare that and go with endocrine therapy alone? I'll talk about what an ESR1 mutation is and some of the updates from the ASCO meeting about the clinical implications of that, having that particular mutation. Then I'll switch focus and talk about antibody drug conjugates, which is an exciting new class of therapies. I'll talk about what's already out there for metastatic breast cancer, some of the new updates that we got, including a new one that we heard about, and some of the toxicities, that sort of thing. And then how do we decide, how do we sequence them? I'll talk a lot about that. And then finally, in terms of symptom management and supportive care, I'll specifically touch on capecitabine and a study that showed how we should be dosing capecitabine. This is also known as Xeloda as the brand name. And then how to manage one of the most common side effects, which is hand-foot syndrome. So starting with some developments in hormone receptor positive, HER2 negative breast cancer. So I know this is kind of a complicated slide, but I'll walk through it. This is our current paradigm of how to approach a patient who's been newly diagnosed with hormone receptor positive, HER2 negative metastatic breast cancer. This kind of schematic was shown by Dr. Stover at our ASCO annual meeting. And so walking through it from top to bottom, essentially when a metastasis or suspicion for metastasis is identified on imaging, the first thing we want to do is a tumor biopsy to confirm that it really is metastatic disease from a breast cancer primary location. Some important things that we want to know are, could there have been a subtype switch, meaning we test for the estrogen, progesterone, and HER2 receptors? Could those be slightly different from the original primary breast cancer? So that's important information that we get from the tumor biopsy. And these days, based on some of the clinical trials that came out of the ASCO meeting last year, we're interested to know exactly what that HER2 status is. Is it positive or is it what we would consider low, because that has treatment implications? So that kind of information comes from the tumor biopsy. And the tumor biopsy can also be sent for genomic testing. That doesn't necessarily have any treatment implications right away, but it can help us plan for future therapies. So some of the things that we're interested in from that genomic testing include, is there an ESR1 mutation, which I'll talk about in some detail? Is there a PIK3CA mutation? That would make a patient eligible for alpelisib, also known as Piqray. TMB stands for tumor mutational burden. So we look at the number of mutations in a tumor. That can have implications for immunotherapy. And then we want to know also, are there things like a BRCA mutation that can be tied to a treatment as well? In some patients, it's really hard to obtain a tumor biopsy because the metastatic tumor might be in a location that's hard to access, or where there's a lot of concern for safety of biopsying, like if it's deep in the lung, for example. So in those patients, it may be appropriate to do what's called a liquid biopsy or a blood test measurement of circulating tumor DNA, which can yield a lot of the same information about those genetic mutations. So then looking at first-line therapy, most patients will get the combination of an endocrine therapy plus one of the class of drugs called CDK4/6 inhibitors, either ribociclib or abemaciclib, so Kisqali or Verzenio. Those two are our currently first choice for CDK4/6 inhibitors. But there are some patients in whom endocrine therapy and palbociclib, or also known as Ibrance, might be appropriate. There are some patients who might need chemotherapy right away, and there are some patients who we would encourage to enroll on a clinical trial. So those are kind of the main options for first-line therapies. Now, in patients in whom are started on that first line therapy. And then there's some question of maybe there's a little bit of progression. It's not super clear, this indeterminate progression box to the right. Those are patients in whom we often repeat genomic testing in the form of a liquid biopsy, looking for that ESR1 mutation, because that can develop as a result of being on therapy. And if that exists, we can switch the endocrine therapy backbone of treatment, switching from an aromatase inhibitor to fulvestrant. Now, if there's pretty clear progression, so going down the left side, definite progression, future treatment options that we can think about include, depending on the PIK3CA mutation status, like I mentioned, alpelisib, or soon we're expecting an FDA approval for capivasertib. For those ESR1 mutation patients, elacestrant was recently FDA approved. That's also known as Orserdu. For patients with BRCA mutations, the class of drugs called PARP inhibitors can be an option. And for those that don't have any targetable mutations, we often can escalate their endocrine therapy to fulvestrant, and we can use the targeted therapy partner of everolimus, also known as Afinitor, that doesn't require a specific mutation to be seen. So most patients can receive that as a therapy option. And in those patients in whom it looks like the disease is rapidly progressing, we oftentimes will think about chemotherapy, or maybe one of this class of drugs that I'll talk about, an antibody drug conjugate. So like I mentioned, in most patients, first-line therapy is going to be a CDK4/6 inhibitor along with endocrine therapy. So what is a CDK4/6 inhibitor? Well, there are signals in a cell that tell the cell to grow and proliferate, and that happens a lot in tumor cells. They grow quickly. So what these CDK4/6 inhibitors do, they inhibit this protein called CDK4/6. So this protein normally along the red arrows is responsible for promoting that cell growth. But when we inhibit it, then cells can't go through their regular growth cycle and reproduce, and therefore go to sleep and eventually hopefully die off. There are 3 CDK4/6 inhibitors that are FDA approved and have been very well studied for metastatic breast cancer. These include palbociclib, ribociclib, and abemaciclib. These were all in the major phase 3 trials, which included hundreds of women with metastatic breast cancer. They were all studied with letrozole as the endocrine therapy partner. That's an aromatase inhibitor. And in terms of comparing between the 3, we generally like to go with ribociclib or abemaciclib at this point in time because the data are slightly stronger for those 2 drugs. That being said, at each individual patient level, it really is depending on the goal of therapy and depending on the potential toxicities as well. Palbociclib is generally considered to be the best tolerated among the 3. Ribociclib has some very particular toxicities, like it can have some effects on the heart as well as the liver. And abemaciclib can also have some liver effects, but it can also cause a lot of diarrhea. So these are really individual factors that we take into account when talking about how to select between the 3 CDK4/6 inhibitors. So some of the interesting data that was presented at the ASCO annual meeting was this clinical trial called the SONIA clinical trial. And the main question they were asking was, is a CDK4/6 inhibitor right away in that first line setting appropriate for everybody with hormone receptor positive metastatic breast cancer? Or are there some patients who could actually delay starting a CDK4/6 inhibitor? So this study looked at patients with, like I said, hormone receptor positive advanced metastatic breast cancer. They looked at both pre and postmenopausal women who had to have measurable disease so they could follow them on the clinical trial and see what was happening. They could have had prior neoadjuvant or adjuvant therapy, meaning treatment for the primary breast cancer. but no prior therapy for the advanced breast cancer once it had become metastatic. They couldn't have visceral crisis. Visceral crisis is defined as breast cancer affecting one of the organs. So, for example, it's in the liver and it's actually causing problems with how the liver functions, or it's in the lungs and producing a lot of fluid, causing the patient to need oxygen, for example. Those are things that define a visceral crisis. And in those patients, we tend to use more aggressive therapies. So, patients who had visceral crisis couldn't join this clinical trial. And patients were randomized to either starting with the combination of an aromatase inhibitor and a CDK4/6 inhibitor, and then at the time of progression, going to fulvestrant, or just an aromatase inhibitor alone, so without that CDK4/6 inhibitor, and at the time of progression, then going to fulvestrant and then adding the CDK4/6 inhibitor in. And what they found was that for patients who started with the combination, they got a longer time out of the combination together. And when those patients had progression and got fulvestrant alone, that time period was shorter that they were on fulvestrant. Patients who were randomized to the other arm, where they started with just endocrine therapy, just an aromatase inhibitor, had a shorter time before they experienced progression. But then when they went on to get fulvestrant and the CDK4/6 inhibitor at that time point, so delayed, they actually got a long time out of that as well. And ultimately, the conclusion of this trial was that these patients reached the same time point after those two sets of therapies, which was that between these two arms, the time to progression overall after that second treatment was very similar. So, other things that came out of this trial was that they showed, like I said, similar time to that second progression time point, but that it doesn't really improve quality of life to have that CDK4/6 inhibitor right away in the first line. And it really prolongs the time on a CDK4/6 inhibitor in total by 16 months. And what this graph is showing is that there was increased toxicity in patients who had that first line CDK4/6 inhibitor. This is looking at the number of toxicity events that were severe. So it was greater in patients who had that CDK4/6 inhibitor right away and therefore had a longer time on a CDK4/6 inhibitor in total. So kind of going back to the schematic here and how this fits in, from the SONIA trial, we now know that perhaps endocrine therapy alone is appropriate in some of our patients. I will say that, in this trial, I mentioned the inclusion criteria. We don't yet know, this is early data, they haven't published these data fully to tell us who are the right patients who can start with just endocrine therapy. For me, it seemed I would be more comfortable having patients on only endocrine therapy alone if they have low disease burden, meaning there's not a lot of metastatic disease throughout the body. If that metastatic disease is located in sites that are not as critical, so more so the bones, for example, rather than critical organs like the liver. And if there's a really long time period between that first primary breast cancer diagnosis and then recurrence and metastatic disease, like if someone had had 10 or more years, that makes me more comfortable that their cancer is progressing at a slower rate and could therefore hopefully be safe to just get that endocrine therapy alone. And for patients in whom their cancer is very strongly hormonally driven, meaning estrogen receptor and progesterone receptor percentages are really high. So it's really dependent on those hormones as opposed to like 10 or 20%, for example. So those are the patients in whom I would really consider just starting with endocrine therapy and adding in that CDK4/6 inhibitor at the time of progression. But like I said, still a lot to be learned here. So to talk about ESR1 mutations, which you may have heard a lot about, especially in the last year when the FDA approval happened, what an ESR1 mutation is. So the estrogen receptor, let me start with that. On the left side in this schematic, this kind of dark grayish area in the estrogen receptor is the binding pocket for estrogen. When estrogen binds to the estrogen receptor, some of the receptor changes configuration. There's a co-activator that binds, and it finds another one of itself that's called dimerization, and then it's able to do the things that it's essentially programmed to do, which is to cause increased cell growth and cause proliferation of a hormonally driven cancer. What an ESR1 mutation is that it allows the estrogen receptor to do that activity without even needing to bind estrogen. So ESR1 mutations can develop when a patient is on an aromatase inhibitor, which brings down the estrogen levels to very low amounts in the body. So when that ESR1 mutation develops, it's allowed the cancer to become smart enough that it doesn't actually depend on estrogen anymore, and the estrogen receptor can just do its effects, like promoting that cell growth without needing estrogen. There was an FDA approval earlier this year for elacestrant specifically in ESR1 mutations, which was really exciting. And so from ASCO, we heard some additional updates on what to do with these mutations. So this is from the PADA-1 clinical trial. This trial was already presented. So the primary results of this trial weren't new to ASCO, but they gave us some updates, which I thought were really interesting. In this trial, they took patients who had hormonally sensitive metastatic hormone receptor breast cancer, no prior treatment. And essentially, they started on that first-line treatment, aromatase inhibitor with a CDK4/6 inhibitor, specifically palbociclib. And they got repeated blood measurements looking for that ESR1 mutation to appear. When it did appear, they were then randomized to switching the endocrine therapy backbone from aromatase inhibitor to fulvestrant, or just staying on that same treatment. So again, they had rising ctDNA ESR1 mutations, but no actual change on their scans. And what they previously reported from this study was that an early switch based on just the ESR1 mutation in the blood, not waiting for the scan to show progression, actually resulted in a longer time to the next progression, to the progression time point on a scan. So essentially that switching to fulvestrant was better. They showed some additional data looking at these ESR1 mutations at ASCO, which was really interesting. What these charts on the left show, green is for patients in whom the ESR1 mutation became undetectable after they continued on treatment. So either they switched or continued on aromatase inhibitor and palbociclib. And what you can see is in patients who had gotten fulvestrant, so who did get that switch, there's more green, meaning more of those patients had undetectable ESR1 ctDNA after 2 months on therapy. And that those who had the ctDNA become undetectable actually had a longer time that they were able to get out of that therapy before progression happened. So that was really interesting. Clearance or looking for no more detectable ESR1 mutation after therapy seems to really mean something. And we also learned from this study that the exact type of mutation in the ESR1 gene and the number of mutations didn't really seem to matter in terms of how effective therapy was. So moving on to the next part of my talk, I wanted to go over what antibody drug conjugates are and some of the new data that we got from ASCO. So antibody drug conjugates are this exciting new class of therapies for metastatic breast cancer. What it is it's an antibody that has a linkage to some chemotherapy molecules. And the way that it works is that if you see panel number 1, antibody drug conjugates circulate in the bloodstream as 3 components. The full form, the antibody conjugated to the chemotherapy, sometimes little pieces of the chemotherapy molecules, and pieces of the antibody without the chemotherapy molecules. They have to circulate through the bloodstream and then kind of generally leave the bloodstream and go to the tumor. The antibody drug conjugate has some properties that allow it to disrupt cancer cells even without the chemotherapy portion of it. So the antibody portion alone, what it can do is bring some immune cells to find the cancer and attack it. That's what panel 3 is showing. And it can also interrupt the normal function of the receptor that the antibody is supposed to find as well. So this is all independent of the chemo that it's attached to. But most importantly, shown in panel 4, its main function is to get internalized into the cell and release that chemotherapy that it does have attached to it. That's what panel 5 is showing, which is that once it's internalized into the cell, the cell has mechanisms where the chemotherapy gets released from the antibody itself, and that chemotherapy disrupts the ability of the cancer cell to grow and reproduce. Interestingly, once that chemotherapy has been released from the antibody, that chemotherapy molecule can actually leave that cell after killing it and affect some of the cells in the area as well. That can happen to other cells that where the antibody wouldn't have bound. So it binds certain cells, it releases the chemo, and the chemo affects these bystander cells as well. So that's a really interesting mechanism of action of how these antibody drug conjugates work. There are 3 FDA-approved antibody drug conjugates in breast cancer. Trastuzumab emtansine is approved for HER2-positive breast cancer. Sacituzumab govitecan is approved for both triple-negative breast cancer and hormone receptor-positive breast cancer. And then trastuzumab deruxtecan is approved for HER2-positive breast cancer and specifically for what's called HER2-low triple-negative breast cancer or hormone receptor-positive breast cancer. What these graphs are showing is their measures of each individual patient's tumor response. So this is all patients in each one of these clinical trials. Did their tumors grow, in which case the bars go upward, or did their tumors shrink, in which case the bars go downward? So you can see that these 3 different antibody drug conjugates, the vast majority of tumors shrank with downward bars. And so these have been really promising treatments that have become FDA approved, and we're still learning a lot about the best patient population to treat them with, the best order in which to give them, but it's a really exciting field that's growing very quickly. Another way to think about these 3 different antibody drug conjugates is by subtype of breast cancer, because I know it's confusing. The names are really long. So for triple-negative breast cancer, sacituzumab is approved as a second treatment or later. And TDXD, which is trastuzumab deruxtecan, the brand name is in HER2, is also approved for second line and beyond, specifically for HER2-low breast cancer. For hormone receptor positive breast cancer, again, that same thing, TDXD for HER2-low breast cancer, and sacituzumab govitecan is approved for the third line and beyond. And then for HER2 positive breast cancer, TDXD is approved in the second line, and TDM1 is as well, also for the second line and beyond, but they were studied against each other and TDXD was better. So we really try to do TDXD in the second line and TDM1, which is trastuzumab emtansine, for the third line and later. So one thing that we heard at ASCO was about a new antibody drug conjugate. This one was called patritumab deruxtecan, and the target of this antibody was HER3. You can kind of tell by the name, the second word deruxtecan is the same as trastuzumab deruxtecan, so it's the same chemotherapy payload that's attached to that antibody. So this was a small study. It was only in 60 patients, but they were primarily looking at how effective was this new medication, patritumab deruxtecan, in these patients. And they included patients with triple-negative breast cancer and hormone receptor positive breast cancer. So you can see here, this is the same kind of waterfall plot. That's the name of this kind of graph that I showed for the 3 FDA-approved antibody drug conjugates. Upward bars are tumor growth, downward bars are tumor shrinkage. So you get the sense that this graph looks very similar to the other ones that I showed before. So it's promising in that most tumors shrunk as a result of being treated with this medication. What these different colors are showing too was that they measured how much HER3 was in the cancer and did that relate to the response. And generally, those with higher amounts of HER3 in the cancer did seem to have more tumor shrinkage, so that probably does impact a little bit. And then they used striped markers to specifically denote patients with triple-negative breast cancer. So you can see that patients with triple-negative breast cancer were pretty even in this cohort as well. So there were a lot of meaningful responses even in triple-negative. So the conclusion here was that this antibody drug conjugate looks promising, but it's a small study. And so we really need to see more data. Some of the toxicities that came from this are pretty similar to other antibody drug conjugates like nausea, fatigue, diarrhea, vomiting, and low blood counts. Those were all pretty similar. Switching gears to sacituzumab govitecan, we did hear an update on this study. This study looked at patients with hormone receptor positive metastatic breast cancer. These are patients who had to have had at least 2 prior chemotherapies before they got treated with sacituzumab. And they were randomized to either sacituzumab govitecan versus the chemotherapy of physician's choice. And the update that we heard at ASCO was that sacituzumab continued to be superior to chemotherapy of the physician's choice. So this is really a good treatment option after 2 prior chemotherapy lines in our patients with metastatic hormone receptor positive breast cancer. So I talked about a lot of antibody drug conjugates. The question that we really still are grappling with is which one is the right one? In all of these different subtypes, there's more than one approved. And so we're still learning about how to select the first one. Is it okay to give another antibody drug conjugate after the first one, for example? So I'm going to talk for a second about trastuzumab deruxtecan, which was FDA approved specifically for HER2 low metastatic breast cancer. So this agent was already studied and proven in HER2 positive breast cancer. And HER2 positive is defined as, when we look under the microscope and grade it, a 3+ grade, which is the highest grade, or a 2+ with an additional confirmatory test that is positive for HER2. Anything that's not 0, so in between HER2 positive and 0 is HER2 low. That's defined as a score of 1+ or a score of 2+, but that confirmatory test being negative. And so that's kind of shown on the left here where the HER2 staining, when we look under the microscope, is brown. So HER2 positive, you can see there's a lot of staining in that top box. HER2 negative, there's almost no brown, so there's very little staining. But HER2 low, there's a little bit of that brown. So that's patients that we're now able to treat with trastuzumab deruxtecan. And we know that among patients with hormone receptor positive metastatic breast cancer, that this entity of HER2 low is almost 2/3 of patients. And that in our patients with triple negative breast cancer, it's about 1/3 of patients that have HER2 low disease and are thus eligible to get trastuzumab deruxtecan. So this was a really interesting study that was presented at ASCO. What they showed was that basically the more you biopsy, the higher the chances of actually finding some HER2 low disease. That happens because breast cancer, even across one tumor and across different metastatic sites, is not always exactly the same. In fact, it oftentimes can be very variable between different sites, and even, like I said, within one tumor site. So the more you sample, it turns out, the more likely it is that you're going to find some sample that qualifies as HER2 low and therefore would allow the patient to get trastuzumab deruxtecan. So what this graph is showing is that by the time patients get a 5th biopsy, which is a lot of biopsies, I don't think patients should get that many biopsies, but in this study, in those who had 5 or more biopsies, 100% of the patients had at some point had a HER2 low result on 1 or more of the biopsies. And what they also showed was that for these patients with triple negative breast cancer, which is the patient population they looked at specifically, in those who were HER2 low, they would have been able to get trastuzumab deruxtecan. But in this study, they were interested in the patients who started out with a HER2 of 0. It turns out that on that first biopsy, if HER2 is 0, if they got a second biopsy, about 1/3 of that group ended up in the HER2 low group, actually, and not just with a 0 result. Again, taking the patients who had HER2 0 from that second biopsy, if they happened to get a 3rd biopsy, another 1/3 of them then converted to HER2 low, and again, weren't just HER2 0, and so on and so forth. So it seems like with each biopsy that patients got, a new HER2 low result was detected in 1/3 of the patient group that underwent that biopsy, which was really interesting. So Kind of on the same thread about trastuzumab deruxtecan, we did see some additional data looking at in our older patients, is it still as effective and what's the toxicity like? And what this is showing is that across 3 different clinical trials comparing age less than 65 versus age greater than or equal to 65, that the effectiveness was very similar, meaning that this works just as well in our older patients. But what we did see was that there was more toxicity. So older patients did seem to have a higher rate of lung toxicity, which is what we really worry about with this drug, with trastuzumab deruxtecan. And overall, in terms of other side effects too, like nausea, vomiting, and low blood counts, those were higher in the older patients as well. So similarly effective, but slightly more toxic. So maybe in our older patients, we should be thinking about dose reducing more quickly in order to make it more tolerable. So to come to the question of, after we've selected one antibody drug conjugate, is it okay to give another antibody drug conjugate? And this is really an area that we don't know very much. We're still only now seeing the initial data, so there's a lot to come here, and the answer is really very unclear. We know that there is some meaningful activity to that second antibody drug conjugate, but that it's pretty short compared to the first one. That's what the chart on the right is showing. This is looking at response with the first one shown in purple versus the second one in pink. So you get the sense that people have a long time on that first one, but compared to that, once they go on the second one in pink, that time of response and the duration of that response is much shorter. So there's still a lot to learn. What this chart on the left is showing is that, is it important to switch the antibody or is it important to switch the chemotherapy that it's attached to? So this was a really small study, so it's not definitive by any means. But what they're showing here is cross resistance, which they defined as a very short amount of time on that second antibody drug conjugate. That suggests that there's resistance. So if you keep the same antibody and the same payload, then there's a lot of resistance. But if you have the same antibody and change the payload, there's still like 60-ish% resistance. Whereas changing both the antibody and the payload was really helpful, or at least just changing the antibody but keeping the same payload. So this is just kind of generating more questions and future data. Like I said, really not definitive. It does tell us that perhaps we can use a second antibody drug conjugate in some patients, but it seems like on that second one, the response really is shorter, and we need a lot more research to help us understand what's most important in terms of choosing how and which one we switch to, essentially. So to kind of summarize, I know this is a really big topic. There's a lot of confusing data here. This is the slide I showed earlier about which antibody drug conjugates are approved in each type of breast cancer. What we learned here is that this new HER3 deruxtecan antibody drug conjugate looked promising, but we need more data. That was across subtypes. We learned that in terms of sacituzumab, specifically for hormone receptor positive metastatic breast cancer, that the data update confirmed benefit. We learned that for trastuzumab deruxtecan in HER2 low breast cancer, the more you biopsy, the more HER2 low you're likely to find, and that it is similarly effective in our older patients, but slightly more toxic. So something for us to think about. And finally, just really a lot to learn in terms of sequencing our antibody drug conjugates. And there's a lot of studies, including clinical trials ongoing, trying to answer this question. So lastly, I'll just touch upon symptom management and supportive care. Capecitabine, also known as Xeloda, is a chemotherapy pill that's used across different metastatic breast cancer subtypes. So this was a study looking at how we dose capecitabine. So patients with metastatic breast cancer were randomized essentially to receiving either a fixed dose of capecitabine, 7 days taking it, 7 days off. So that's what FD77 means, was they got a fixed dose at 1,500 milligrams twice a day, taking it for 7 days, and then 7 days off. Versus a weight-based dosing, which is also very commonly used. So specifically it was 1,250 milligrams per meter squared. That's just a weight-based dosing. And similarly, twice a day, but for 14 days on, followed by a 7-day rest period. And the purpose was to compare the effectiveness of these two different dosing schemes as well as the toxicity. And what this study showed was that the effectiveness was actually very similar between these two different dosing schemes. So you would think that giving a weight-based dose and giving it for 2 weeks on followed by 2 weeks off might be more effective, but they were actually statistically very, very similar between the two different arms. On the other hand, toxicity was very different. So looking at this chart, the 4 very common toxicities with capecitabine include diarrhea, hand-foot syndrome, mucositis, which is sores in the mouth, and neutropenia, which is low blood counts. In the fixed dose column, you can see the number of patients and then in parentheses the percentages compared to the weight-based dosing with 14 days on, 7 days off. And you can see that the percentages of these toxicities are much, much higher. So for example, 20% of patients had diarrhea with that higher dosing. 15% of patients had hand-foot syndrome as compared to about 4% of patients in the fixed dose arm. And the same held up for mouth sores and for low blood counts. So the conclusion from this study was that there was really a similar efficacy between these two different dosing schedules, but a lot less toxicity with that fixed dose, 1,500 milligrams twice per day, 7 days taking it, 7 days off. So we should really be thinking about using that dosing schedule because it can spare our patients a lot of toxicity. It also resulted in a lower rate of patients needing to discontinue capecitabine because of toxicities and in needing an additional dose adjustment. So that's all really meaningful as we think about how to keep our patients on therapies that we know are working. They have to be tolerable. So perhaps starting with this fixed dose schedule can make it more tolerable and minimize toxicity. And finally, how to deal with hand-foot syndrome, which is a common issue, as you saw from the table that I just showed with taking capecitabine. This was a really interesting study. This was for patients with breast or GI cancers who were starting on capecitabine, and it was trying to figure out how to preventatively manage hand-foot syndrome. There were some data that this oral medication called celecoxib, which is like a cousin drug to aspirin, could help with hand-foot syndrome. But taking a pill, as you can imagine, in addition to taking capecitabine, also caused a lot of problems and toxicities itself. So the theory behind this clinical trial was, what if we give the cream version of that medication? So patients going to start capecitabine were randomized to either this medication called diclofenac, which they applied to their hands during 4 cycles of capecitabine twice per day, versus just a placebo cream, essentially. And what they were interested in was how frequently did hand-foot syndrome happen. And what they found was that in patients who got the diclofenac gel, the rate of serious hand-foot syndrome was way lower, which you can see on the left, 3.8% with diclofenac compared to 15% with the placebo gel. And for any grade of hand-foot syndrome, grade, it just means how severe was it. So for any amount of hand-foot syndrome and for severe hand-foot syndrome, in both of those cases, the diclofenac gel was associated with a lot lower rate of hand-foot syndrome as compared to the placebo gel. So I thought this was a really interesting study, especially in thinking about how we dose capecitabine and then thinking about how we can prevent some of these potentially serious toxicities that can lead to early discontinuation of a drug that's working. So these are things that are going to result in a change in my practice. I was already giving the fixed dose capecitabine. We tend to do that here at Memorial Sloan Kettering, but I've been really interested in now using this gel and have been prescribing it to some of my patients in order to prevent that hand-foot syndrome. So just to recap, these are things we talked about today. We talked about whether first-line CDK4/6 inhibitor is appropriate for everybody, or are there select patients in whom we can start with just endocrine therapy alone. We talked about ESR1 mutations and how response on treatment, clearing that ESR1 mutation is a good sign in terms of how long patients can get out of their therapy. We talked about antibody drug conjugates across the different metastatic breast cancer subtypes and learned a little bit about how we can choose the right antibody drug conjugate and how do we sequence them one after another. And then I just reviewed capecitabine dosing and hand-foot syndrome management. So with that, I'll stop here. I'm happy to take questions and have a robust discussion. Of course, wanted to say thank you so much for joining today, for listening. Thank you so much to all of our patients and their families and caregivers. Thank you to Share Cancer Support. You guys all make this possible, this kind of research possible by participating in these clinical trials with us. Thanks to everyone, of course, at my center that I work with. I have such a great team that I'm very thankful for. And thank you to the presenters and investigators who shared their work at our ASCO annual meeting, who are doing really important work of moving the field forward. So I'll stop there. I will stop sharing my screen and open up for questions.
So yes, thank you. We're going to start the Q&A. We did receive some submitted questions when you registered for the webinar, and you can still submit the questions in the Q&A section at the bottom of your screen. We're going to try to get through all of them, but we may not be able to due to time constraints. And we're going to go through some that were submitted prior to the webinar. You talked about the SONIA trial and wonder about the implications of the SONIA trial as far as using that data with the different CDK4/6s, or is it really just for palbociclib?
Yeah, that's a really good question. So for the SONIA trial, they used palbociclib as the CDK4/6 inhibitor, whether initially or later on following progression. I think that we can probably extrapolate that data across different CDK4/6 inhibitors. I mentioned that they're all similar mechanisms of action. There's definitely different toxicities, but we do have some data really supporting ribociclib and abemaciclib as kind of the more stronger CDK4/6 inhibitors that have more of a benefit. So a lot of us have chosen to start with those two, and kind of thinking about palbociclib in that similar population I mentioned who should get endocrine therapy alone, maybe those in whom the disease biology seems a little bit slower growing as opposed to more aggressive. So we're still learning about how to select and what's the best one for which individual patient, but I will say that most of us are kind of moving towards ribociclib and abemaciclib. I mean, the question is, we're not sure. We don't know for sure if we can extrapolate those data, but I would feel comfortable doing so, meaning that in patients in whom I selected endocrine therapy alone, who I felt comfortable doing that, at the time of progression, I would be comfortable giving any of the CDK4/6 inhibitors that I felt was right for that particular patient. But we don't know for sure.
So we have another CDK4/6 question. Some people before the CDK4/6s, obviously we have had advancements in treatment. And we often wonder if depending on the line that you came in on, that some of these new advancements came in after you were already maybe had the CDK4/6 or you had the PIK3 mutation,
Yeah.
right? So how do you, can you go back to that and try the drug again? Or what are the new CDK4/6s? Like, how do you approach that in your patients?
Yeah, that's always a tough question. And there's definitely no right path for sure. So in thinking about like a new diagnosis, I showed that kind of chart of how we think through the different therapies. We often start with CDK4/6 inhibitor. We test for these different mutations to think about future options. And eventually, with enough progression events on these endocrine therapies, eventually the breast cancer evolves to appear resistant to the endocrine therapies, meaning that time on each medication or set of medications gets shorter and shorter. And eventually it becomes time to use one of these new antibody drug conjugates or just traditional IV chemotherapy. So we think of kind of that endocrine sensitive box moving into the endocrine resistant box. That's for someone with newly diagnosed disease. But like you were saying, some of our patients, for whatever reason, may have even started on chemotherapy. For example, those who had a lot of disease right away. So that term I use, like visceral crisis, for example, breast cancer impacting one of the organs may have led to starting with chemotherapy or an antibody drug conjugate. Or like you were saying, in some patients, that was all that was available at the time, and now we have all these new therapies and we're learning about them. It's not really clear if it's okay to go back. Certainly, if someone's shown that they've become endocrine resistant and it isn't getting a meaningful amount of time out of these pill therapies, these endocrine therapies, then it's probably not safe to go back and give them additional endocrine therapy. But in someone in whom, if that was the only thing that was available, or in whom we just needed some quick disease control to use chemotherapy, it can definitely be an option to go back and use some of those endocrine therapies at that time.
Okay, so we have another question that was submitted live, and it's talking about the ESR1 mutation. And you had mentioned that it was caused from treatment. And the question is wondering whether a liquid biopsy or a blood test could be performed to determine if this mutation has developed, and at what point in treatment do you typically look for that ESR1 mutation? And also the question is asking about de novo MBC. When do you typically see this ESR1 mutation showing up?
Yeah. So it's very rare to find an ESR1 mutation upon a new diagnosis of metastatic breast cancer. That's de novo. De novo meaning like there was no primary breast cancer before. The first time they're diagnosed, they found out they had stage 4 breast cancer right at the time of diagnosis. It's extremely rare to find these ESR1 mutations because they really develop as a response to treatment, and in particular to the aromatase inhibitors. So it's really during aromatase inhibitor therapy that this ESR1 mutation can come up. Now, in a lot of our breast cancer patients who had an early stage breast cancer initially, who may have gotten 5+ years of aromatase inhibitor, they certainly can have a tumor that develops that ESR1 mutation. We really only test for this mutation in the metastatic setting. So once someone has developed metastatic disease. In someone who has a long history of aromatase inhibitor therapy, particularly in someone who was taking aromatase inhibitors and then still developed metastatic disease, those are definitely patients in whom it would be worth testing upfront for ESR1 mutations. And that can be done both on a tumor biopsy or a liquid biopsy. In patients who are de novo, who had no prior exposure to any endocrine therapy, it's during therapy that testing can be warranted. And we're still, like I was saying, really learning a lot about this area. I would say it's pretty clear that upon progression, it's definitely worth testing, meaning someone on their first line therapy who has any sign of progression on a scan, whether a little bit of progression or a lot of progression, I always try to send the liquid biopsy at that time point to look for that ESR1 mutation. Now, the question of is it worth during treatment? I showed that data from the PATA-1 study that testing there without imaging progression can still be really useful and can guide the change in treatment. So I think that's something to think about. But testing at the time of progression is actually FDA approved. It's insurance covered. So that's definitely a time point in which I would do it. But these in-between times, it's a little hard because what if you test early, but you miss it? Then you have to send another one later on, and that can run into a lot of insurance issues. So that's really the unclear part. But upon progression, definitely worth testing at that time, in my mind.
Okay. Yeah, that makes a lot of sense. So we have a few questions about the HER3 ADC, and really wondering, is it different antibody target than sacituzumab? And in sequencing, well, obviously it's in clinical trials, so we really don't know a lot of answers, but it looks so promising across all of the subtypes, correct? I'm understanding that correct?
It does
So
in a
yeah,
very
so if
small
you could,
patient population, but yeah, happy to talk about that.
right. So yeah, if you could just maybe talk a little bit about that, because
Sure,
there's a
yeah,
lot of interest in that.
yes. So it's really hard to keep track, I know, because there's so many of these different antibody drug conjugates. So sacituzumab, the antibody is directed against something called TROP2, which is found in a lot of triple negative breast cancers, but can be found in hormone receptor positive breast cancers as well, which is why it's FDA approved in both of those types. The thing that sacituzumab is attached to, that govitecan chemo payload, is actually very similar to deruxtecan. It's like a very similar molecule in the same class. On the other hand, trastuzumab is looking for HER2. It's an antibody against HER2, which is why it's used in HER2 low and HER2 positive breast cancer. So HER3 is similar in that the antibody finds HER3. HER3 and HER2 can together form a complex, kind of like that ESR1 complex that I showed, in causing their downstream action. So there is some relatedness to HER2, but it is a different antibody target entirely. So it's looking at HER3. And then again, I mentioned the payload being very similar as well. So that's the part that we still don't really understand, is which antibody to start with and which payload. And then at the time of progression, does it make more sense to switch the antibody or to switch the payload or to switch both? And ideally, you would switch both. But what we really need is just more options, because we still really only have for any given subtype, 2 different antibody drug conjugates max. Oftentimes there's overlap in that payload or in that antibody. And so there's just not enough options out there, which is why the HER3 antibody would help in like adding an additional tool in the toolbox, for example. And it's really interesting that it seemed to work across subtypes. But again, 60 patients is really small. So it really needs to be tested in a major phase 3 trial before we can bring it to our patients in clinic, essentially. So there's still a lot more to come.
So
This was
do you
really
know,
early data.
yeah, but do we know other clinical trials enrolling for that?
Yeah, that
It-
clinical trial that I showed, actually, it's like a 3-part clinical trial. They just reported part A, but they're expanding their cohorts and continuing to enroll more patients on that study. So they're going to present parts B, and for whatever reason they named it part Z, but there's 3 different parts. And so those will come in the next few years. We'll hear more about that data. So that's actively enrolling, I believe.
Great. So I'm curious, we have the other, antibody drug conjugates that are targeting HER2, and
Mhm.
this is HER3. And so it seems, one would wonder if it's so different that if someone has had a good run on the sacituzumab and, is it predicted that that because it's different, it's on the HER3
Right.
target, would they benefit? Would you recommend the clinical trial? What are they thinking?
Yeah, that's a good question. So patritumab deruxtecan, that HER3 antibody, it's got that deruxtecan payload, which is actually pretty similar to the govitecan payload with sacituzumab. So while it is an antibody switch, it's a very, very similar payload, even though the word is different. It's like the same class. So that's where we're seeing still that cross resistance, some degree of cross resistance. The ideal thing would be to change both, but we just don't have enough antibody drug conjugates to be able to do that. So that's a good question. I would say that if, it's as always very individualized, if there are other meaningful standard of care treatment options, it perhaps would make sense to do that before trying another antibody drug conjugate. Maybe time away from this kind of class in general could actually help, like giving the body time to see a totally different therapy, like chemo, for example, and then coming back to an antibody drug conjugate. Would that make that second one a little bit more effective than just doing them back to back right away? That's something that we're thinking about as well. But if it seems like treatment options are limited at that point, we always encourage clinical trial enrollment because there are these exciting new drugs that look like they could be working really well.
I think maybe we have time for one more question. When we talk about the trial with the 7-7, the dosing, when you're looking at that, a lot of patients have already decreased to their dose down because of the toxicity. What do you think about the 7-7? Can patients maintain that lower dose and continue on the 7, try the 7-7, or do they have to actually increase their dose?
No, I
To that
actually
fixed
find,
dose?
yeah, I actually find that fixed dose 1500 twice a day, 7 on, 7 off, really well tolerated, much better tolerated. So I start my patients in whom I'm giving capecitabine on that fixed dose. Are you specifically asking about patients who are like at an even lower dose than that got dose reduced? Yeah,
Yes.
I mean, I think that if the toxicities are manageable, so like the hand-foot syndrome gets under control or whatever toxicity it was that led to that dose reduction, if that can be controlled through supportive measures, then yeah, increasing back up to that dose would be a good goal. But the good thing is we found out from this trial that you don't need to try to increase beyond that to the higher weight-based dosing to 14 days on, 7 days off. It doesn't seem worth it. It doesn't seem worth the toxicity. So just using that lower fixed dose as a benchmark is the way to go. So if the toxicities are managed, trying to use that goal dose rather than the weight-based dosing at a more frequent schedule is totally fair.
Okay, great. Thank you so much, Dr. Shen, for this informative program. And thanks to all of you in the audience for participating and submitting questions. Make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media as well. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. This concludes the webinar. Thank you.
Thanks, everyone.